what's another classic workflow that you could have a shot at here? And we were going to call this the impressions and bite in dentures. And what you're doing here is taking the patient's existing denture, and we're going to take advantage of it by taking impressions and a bite in their existing denture. A very common workflow in the analog world or the traditional world, and the procedures are identical for the digital. So this could be an entry point into the digital process by following the same clinical technique that you would traditionally do by taking impressions and a bite registration in a patient's existing denture. This could be scanned. Now, this could be scanned with a laboratory scan by the laboratory, or if you have one, or probably a very popular technique is going to be to do a chairside or a chairside scan with a intraoral scanner. And there's a lot of advantage to do this, and something that I think you should embrace, because at a infection control aspect, we could keep the dentures in the operatory. We could scan them in the operatory. We could then remove the impression material, give it back to the patient while they're still in the operatory. So nothing leaves other than an electronic file to the laboratory that gives the information of the impressions and the bite to the laboratory. So a chairside scan is something to work at, and it's certainly not rocket science to do so. If you've been doing chairside scanning, you'll find this to be relatively easy to do. So we have a virtual mounting. Whether we do a lab scan or a trio scan, we get a virtual mounting, and then again, using the information of the patient's existing denture. And we're going to talk about this a little bit more detail, because you want to look at the patient's existing denture and treat it like a try-in, so that we could use it as a reference for the laboratory to help guide the process of setting the teeth. And again, our crosshairs here is it's a ton of information that the laboratory has been able to start with. Midline, incisal length of the teeth, occlusal plane, the bipupillary length. There's a ton of information given here that, again, could be ghosted in at any time during the process of setting the teeth. So same idea, do a try-in, then our final denture, or you could do a final denture if you don't want to do a try-in, if you're confident in the information. So you got plenty of choices, but the process, again, clinically is the same as you would do for a traditional denture. So we have this. Now, when we take impressions in a denture and a bite, it's like our wax rim registration. In the sense, we got a ton of information here. But as I said, you try this in, so it's treated like a try-in, where we could then make comments to the laboratory, let's say midline. Do we want to change the midlines? In other words, you try this in and you look. And is the midline of their existing denture where you want it to be? If so, great, no change. Easy for the lab. They just line up to the midline of the existing denture. If you want to change, maybe you want to put a mark on the denture so that when you scan it, the mark will pick up, or you wanted to write down a note 2 millimeters to the patient's left, or etc. So however you want to make this communication, but the most important thing is that you communicate it. And so the laboratory is not just like guessing, no reason to. They could use your notes and appropriately set the occlusal plane accordingly. Same thing like with the maxillary incisal length. You look at the patient's existing denture, and is that where you want the incisal length to be, or you want it to be longer, shorter, and communicate that information to the laboratory. So doing this try-in is really an essential way to start your communication process to the laboratory, so that when they've got this in front of them, a scanned denture, they'll know what to do. They'll know what to accept, what not to accept. So this is the evaluation process that's so important. And just kind of a note here as I look at this, the intent was to increase the patient's vertical dimension And I know this patient, because the incisal length in the upper, we wanted to keep the same, but we wanted to increase the length of the lower incisal teeth to the new vertical dimension. So this is a very easy graphic to understand and to communicate to the laboratory on what to do. So the vertical dimension, the bite record was taken at the desired vertical dimension, and we're going to lengthen the mandibular incisal teeth to this new vertical dimension. So that'll satisfy my desire to see the patient's lower incisal teeth, which disappeared during the process of settling. So again, this chart on the left here is just a suggested chart. It is part of our prescription. If nothing else, it's a reminder of things that you should look at, and then jot down the little notes so that you can make some level of communication to the laboratory. A couple of tips. Remember, this particular process of taking impressions is a closed mouth impression. In other words, whenever you add border molding material or a wash material to the for the impression, we always put the patient back into a centric occlusion, so we don't lose sight of our occlusal relationship. So when we do that, then we have the patient do functional movements and O's and E's and smiling and whatever in a closed relationship. Obviously, on the lower arch, you have to have them open to have to move their tongue to record the lingual, but then we again close them right back down and try to get the physiologically movements in a closed relationship. So you don't have to have your fingers in the patient's mouth, and we tend to get more of a physiological border mold. Very good technique for taking impressions. We refer to it as a closed mouth functional impression technique, but it's inherent in this particular process of doing impressions in a denture. Oftentimes we get little knife edge ridges of impression material. I strongly recommend either you or you ask the laboratory to thicken up those borders because it scans better by having a little more of a rolled border. So if you don't want to lose that extension, it's really best to kind of, add a little material there just to thicken up. It just makes for a better scan, or give the permission for the scan. And something I'm very keen on is to have the laboratory, and you could do a intraoral scan of the patient's denture, chairside scan of the patient's existing denture. Takes a couple of minutes to do that. Transfer it electronically, have the laboratory make you what they're calling a copy denture. So there's no impressions taken in these dentures. No, they're just getting the dentures copied. And we're going to use those as impression trays. So it's kind of custom impression trays with the patient's existing teeth. Wonderful way to do this particular workflow where it is impressions in a denture technique. So I strongly recommend considering that. I think personally that particular workflow, by having the patient's existing dentures copied and then going forward using that as to take impressions in, now you could mark them, you could grind them, you could add to them, you could put denture adhesive on them, you could do things that you necessarily would not be able to do on their real dentures. You could do it on their copy denture. And I think it's an excellent way to, as a workflow, and a vast majority of patients do enter for treatment with an existing denture. I'd say in the range of 80%, maybe 90% of patients are going to already have an existing dentures, and those who don't are probably immediate dentures, which is a different workflow. So I mentioned that not to try to steer you any which way, but just I find it a good workflow. I really do. And if you're a casual provider of removable and haven't been able to really do a lot of patients at in a sense of practice makes perfect. And if you don't have a lot of removable in your practice, I think this is a great workflow instead of starting from scratch, to use the patient's existing dentures as a excellent starting point. So I do recommend it.